Hello future nurses. Today we are diving deep into the antepartum period. This is a huge topic for your nursing school exams and of course the NCLEX. The term antepartum might sound fancy, but it simply means the time before childbirth. Think of it as the entire pregnancy journey, from the moment of conception all the way until labor begins. You might also hear this period called the prenatal period. These two terms are often used interchangeably, so don't let that trip you up. It's all about supporting the mother and monitoring the developing baby to ensure the healthiest possible outcome for both of them. This is a critical time where your nursing knowledge can make a world of difference. To really master this topic, we have to start with the foundational vocabulary. First up, let's talk about trimesters. Pregnancy is typically divided into 3 trimesters, each lasting about 13 weeks. The first trimester covers weeks 1 through 13. The second trimester spans weeks 14 through 26. Finally, the third trimester goes from week 27 until birth. Understanding what happens in each trimester from fetal development to the mother's physical and emotional changes is essential. You'll need to know which milestones, assessments, and patient education points are relevant for each specific stage of the pregnancy journey. It's like a roadmap that guides your nursing care from start to finish. Another key concept is calculating the estimated due date, or EDD. The most common method you'll see on the NCLEX is Nagel's rule. It's a simple formula: take the first day of the mother's last menstrual period, subtract 3 months, and then add 7 days and 1 year. For example, if the last menstrual period was August 10th, 2024, you would subtract 3 months to get May 10th, 2024. Then add 7 days, which brings you to May 17th. Finally, add 1 year to get an EDD of May 17th, 2025. It's important to remember that this is just an estimate. Only a small percentage of babies are born on their exact due date, but it gives us a vital target for planning care. Let's do a quick NCLEX style question to practice. A client tells you her last menstrual period started on October 20th, 2024. Using Nagel's rule, what is her estimated due date? First, take the LMP October 20th, subtract 3 months, which brings you to July 20th. Now add 7 days, which gives you July 27th. Finally, add 1 year. The estimated due date is July 27th, 2025. The rationale here is the direct application of the formula LMP minus 3 months plus 7 days plus 1 year. Mastering this simple calculation will score you easy points on your exams, so practice it until it becomes second nature. Now let's decode some of the most common abbreviations you'll encounter in maternity nursing, gravida, and parity. These terms give us a quick snapshot of a woman's obstetric history. Gravida refers to the total number of times a woman has been pregnant, regardless of the outcome. This includes her current pregnancy. So, a woman who is pregnant for the very first time is a primigravida. A woman who has been pregnant multiple times is a multigravida. It's a simple count of every confirmed pregnancy. Think of gravida as the total number of times her body has geared up for the pregnancy journey. Parity, on the other hand, is a bit more specific. It refers to the number of pregnancies that have reached 20 weeks of gestation or more. It does not refer to the number of fetuses delivered, so twins or triplets from one pregnancy count as one for parity. A woman who has never carried a pregnancy to 20 weeks is a nullipara. A woman who has given birth once after 20 weeks is a primipara, and one who has done so multiple times is a multipara. For example, a woman who is pregnant now, had 1 full-term birth, and 1 miscarriage at 10 weeks would be gravida 3, para 1. To get an even more detailed history, we use the GTPAL system. This acronym breaks down parity into more specific components. G stands for gravida, the total number of pregnancies. T is for term births, meaning pregnancies delivered at 37 weeks or later. P is for preterm births, which are deliveries between 20 weeks and 36 weeks and 6 days. A is for abortions, which includes both spontaneous miscarriages and elective terminations before 20 weeks. Finally, L stands for living children. This system gives healthcare providers a comprehensive and quick overview of a patient's obstetric history, which is crucial for assessing risk. Let's work through a GTPL example. A client is currently pregnant. She has 2 living children. Her first child was born at 39 weeks and her second was born at 35 weeks. She also had 1 miscarriage at 8 weeks. What is her GTPL? Let's break it down. G, gravida. She's pregnant now, plus 2 previous births, plus 1 miscarriage, so G equals 4. T, term. Her first child was born at 39 weeks, so T equals 1. P, preterm. Her second child was born at 35 weeks, so P equals 1. A, abortion. She had 1 miscarriage at 8 weeks, so A equals 1. L, living. She has 2 living children, so L equals 2. Her GTPAL is 4, 1, 1, 1, 2. Practice these until you can solve them in your sleep. The journey of pregnancy begins with conception, the moment a sperm fertilizes an ovum or egg to form a zygote. This incredible event typically happens in the fallopian tube. The newly formed zygote then begins a rapid process of cell division as it travels toward the uterus. About 6 to 10 days after conception, it implants itself into the uterine wall, a process known as implantation. This is a critical step, and sometimes it can cause slight spotting, which might be mistaken for a light period. Once implanted, the zygote is now called an embryo. This early stage is when all the major body organs and systems begin to form, making it a highly sensitive period. As the embryo develops, it is surrounded by 2 membranes, the chorion and the amnion, which form the amniotic sac. This sac is filled with amniotic fluid, a clear, slightly yellowish liquid that serves several vital functions. It acts as a cushion protecting the fetus from physical injury. It helps maintain a constant temperature, preventing heat loss. It also allows for freedom of movement, which is essential for musculoskeletal development, and importantly, it prevents the embryo from tangling with the membranes. The volume of amniotic fluid gradually increases throughout the pregnancy, and monitoring its level is a key part of fetal assessment. The placenta is another amazing organ that develops specifically for pregnancy. It begins to form at implantation and is fully functional by the 12th week. The placenta acts as the interface between the mother and the fetus. It has 2 main jobs, metabolic and endocrine. It facilitates the transfer of oxygen and nutrients from the mother to the fetus and removes waste products like carbon dioxide from the fetus back to the mother. It also produces essential pregnancy hormones such as HCG, progesterone, and estrogen, which are crucial for maintaining the pregnancy and preparing the mother's body for birth and lactation. The umbilical cord, which contains 2 arteries and 1 vein, connects the fetus to the placenta. Fetal development follows a predictable pattern. In the first trimester, all major organ systems are formed and the heart begins to beat. By the end of this trimester, the fetus has a human-like appearance. The second trimester is a period of rapid growth in length and weight. The mother will likely start to feel fetal movements known as quickening, typically between 16 and 20 weeks. The fetus can hear sounds and even swallow. In the third trimester, the fetus continues to grow and gain weight, primarily fat. The lungs mature and the fetus moves into a head-down position in preparation for birth. Knowing these milestones helps you educate your patients and identify any potential deviations from normal development. One of the first things you'll teach patients about is how to recognize the signs of pregnancy. We categorize these into 3 groups: presumptive, probable, and positive signs. Presumptive signs are the subjective changes the woman experiences, like amenorrhea, which is a missed period, fatigue, nausea and vomiting, and breast tenderness. These signs suggest pregnancy, but they could also be caused by other conditions. For example, stress can cause a missed period, and fatigue can be a symptom of many things. Therefore, we can't confirm a pregnancy based on these signs alone. They are clues that prompt further investigation. Probable signs are the objective changes observed by an examiner. These signs make pregnancy much more likely. They include a positive pregnancy test, which detects HCG, Goodell's sign, or softening of the cervix, Chadwick's sign, which is bluish discoloration of the cervix and vagina, and Higar's sign, softening of the lower uterine segment. Other probable signs are Braxton Hicks contractions, which are irregular, painless practice contractions, and ballottement, where the examiner can feel the fetus rebound when the cervix is tapped. While these are strong indicators, they are still not 100% definitive, as some rare medical conditions can mimic them. The only way to be absolutely certain of a pregnancy is through the positive signs. There are only 3 visualization of the fetus by ultrasound, hearing the fetal heart tones via Doppler or fetoscope, and palpation of fetal movements by an experienced examiner. These signs can be directly attributed to the fetus and cannot be consent to Wayne Buenas consent and then any undensent os dent huntiland and under condition. When you see a fetal heartbeat on an ultrasound screen or hear it with a Doppler, you know for sure that a new life is developing. This is a key distinction for the NCLEX. Know which signs fall into which category. Equally important is teaching patients to distinguish between normal discomforts and serious warning signs. It's normal to feel tired or have morning sickness. However, some symptoms require immediate medical attention. These warning signs include vaginal bleeding, a sudden gush of fluid from the vagina, which could indicate ruptured membranes, severe abdominal pain, persistent vomiting, also known as hyperemesis gravidarum, or signs of preeclampsia like severe headaches, vision changes, and swelling in the hands and face. Educating patients on when to call their provider is a critical nursing responsibility that can save lives. Always emphasize that it's better to be safe and call rather than wait and worry. Pregnancy triggers a cascade of physiological changes that affect nearly every system in the mother's body. In the first trimester, hormonal shifts are pretty dramatic. Rising levels of estrogen and progesterone cause many of the early symptoms like breast tenderness and enlargement as the body prepares for lactation. The uterus begins to grow, although it's not yet palpable above the pubic bone. Increased blood volume and cardiac output begin to meet the metabolic needs of pregnancy. This can lead to fatigue as the body adjusts. Nausea and vomiting or morning sickness are also common due to hormonal changes and can occur at any time of day. The second trimester is often called the honeymoon phase of pregnancy. Many uncomfortable symptoms of the first trimester often subside. The uterus grows larger and rises out of the pelvis, making the pregnancy visibly apparent. This is when the mother typically starts feeling fetal movements or quickening, which is an exciting milestone. The skin may undergo changes such as the linea nigra, a dark line down the abdomen, and chloasma or brownish patches on the face. Blood pressure typically decreases slightly due to peripheral vasodilation caused by progesterone. The third trimester is all about preparing for birth. The fetus grows rapidly, putting significant pressure on the mother's organs. This can lead to frequent urination, shortness of breath, and heartburn due to a displaced stomach. Edema in the feet and ankles is common because of impaired venous return. Braxton Hicks contractions may become more frequent as the body practices for labor. The mother web may experience a surge of energy known as nesting in the final weeks. Psychosocial changes are just as significant as the physical ones. The first trimester is often a time of uncertainty and ambivalence. The mother is accepting the idea of being pregnant. During the second trimester, the fetus becomes more real. This is a period of accepting the baby. The third trimester focuses on preparing for parenthood and birth. The mother may experience anxiety about labor and her ability to be a good parent. As a nurse, your role is to provide emotional support through all these stages. Proper nutrition during pregnancy is fundamental for the health of both the mother and the developing fetus. A well-balanced diet provides the building blocks for fetal growth and helps the mother maintain her own health and energy levels. We recommend an increase of about 340 calories per day during the second trimester and about 450 calories per day during the third trimester. It's not about eating for two in terms of quantity, but rather about the quality of the food. The diet should be rich in protein, calcium, iron, and folic acid. These nutrients are essential for fetal tissue growth, bone development, maternal red blood cell production, and preventing neural tube defects, respectively. Folic acid is so important that supplementation is recommended even before conception. A daily intake of 400 to 600 micrograms of folic acid is crucial for preventing major birth defects of the baby brain and spine, like spina bifida. Iron supplements are also commonly prescribed, especially during the second and third trimesters, to prevent iron deficiency anemia as the mother's blood volume expands significantly. When teaching patients about iron supplements, it's important to advise them to take it with a source of vitamin C like orange juice to enhance absorption, and to be aware of common side effects like constipation and dark stools. Weight gain is another critical aspect of prenatal care. The recommended amount of weight gain depends on the mother's pre-pregnancy body mass index, or BMI. For a woman with a normal BMI, which is between 18.5 and 24.9, the recommended weight gain is typically 25 to 35 pounds. Underweight women should gain more, while overweight and obese women should gain less. Gaining too little weight can lead to a low birth weight baby, while gaining too much can increase the risk of gestational diabetes, preeclampsia, and the need for a cesarean section. We monitor weight at every prenatal visit to ensure it's on a healthy track. Beyond diet, there are other lifestyle factors to consider. Adequate hydration is key, so encourage patients to drink plenty of water throughout the day. We also advise them on what to avoid. This includes unpasteurized dairy products, certain soft cheeses, raw or undercooked meat and fish high in mercury like swordfish and king mackerel due to the risk of listeriosis and mercury poisoning. Alcohol and illicit drugs should be avoided entirely as they are known teratogens that can cause severe harm to the fetus. Smoking should also be stopped as it's linked to low birth weight, preterm birth, and other complications. Consistent prenatal care is the cornerstone of a healthy pregnancy. The typical schedule for prenatal visits for a low-risk pregnancy is once a month for the first 28 weeks, then every 2 weeks until 36 weeks, and finally weekly until birth. At each visit, we perform a series of routine maternal assessments. This includes checking the mother's weight, blood pressure, and urine for protein and glucose. We also measure the fundal height, the distance from the pubic bone to the top of the chiakidic bone of the uterus, which should roughly correspond to the number of weeks of gestation after 20 weeks. These simple checks can help us spot potential problems like preeclampsia or fetal growth issues, GK growth issues early on. Fetal assessment is just as important. At every visit starting late in the first trimester, we listen for the fetal heart rate using a Doppler. A normal fetal heart rate is between 110 and 160 beats per minute. We also ask the mother about fetal movement, especially in the second and third trimesters. A decrease in movement can be a sign of fetal distress and requires further evaluation. This consistent monitoring provides reassurance and helps ensure the baby is thriving inside the womb. It's a simple yet powerful way to check on the baby's well-being between more comprehensive tests. Several routine laboratory tests and screenings are performed at home throughout the pregnancy. At the initial visit, we'll draw blood to determine the mother's blood type, Rh factor, and check for anemia. We also screen for infections like syphilis, hepatitis B, and HIV, and check for immunity to Between 24 and 28 weeks, all pregnant women are screened for gestational diabetes with a 1-hour glucose tolerance test. Around 35 to 37 weeks, a vaginal and rectal swab is taken to screen for Group B Streptococcus or GBS, a type of bacteria that can be harmful to the newborn if not treated with antibiotics during labor. Ultrasound is a key diagnostic tool used at various points in pregnancy. An early ultrasound can confirm the pregnancy, determine the gestational age, and check for a heartbeat. The most common ultrasound is the anatomy scan, performed around 18 to 22 weeks. This detailed scan examines the fetus's anatomy from head to toe to look for any structural abnormalities. It can also confirm the location of the placenta and check the amniotic fluid level. Later in pregnancy, ultrasounds may be used to monitor fetal growth, check the fetal position, or as part of a biophysical profile to assess fetal well-being if there are any concerns. While most pregnancies proceed without major issues, some are considered high risk from the start. This means the mother or fetus has a higher chance of experiencing complications. Adolescent pregnancies are high risk due to both physical and psychosocial factors. Teenagers are more likely to have poor nutrition, receive late prenatal care, and develop preeclampsia. Pregnancies in women over the age of 35, known as advanced maternal age, also carry increased risks, including a higher likelihood of gestational diabetes, hypertension, chromosomal abnormalities in the fetus, and cesarean delivery. These patients require more frequent monitoring and specialized care. Multifetal pregnancies, such as twins or triplets, are automatically classified as high risk. The mother's body is under significantly more strain, increasing her risk for complications like preeclampsia, gestational diabetes, and severe anemia. The fetuses are at a much higher risk for preterm birth and low birth weight. Management of a multifetal pregnancy involves more frequent prenatal visits, more ultrasounds to monitor the growth of each fetus, and detailed education on the signs of preterm labor. It's a delicate balancing act to keep both the mother and her babies healthy for as long as possible. Several major complications can arise during pregnancy, and you must know the key signs for the NCLEX. An ectopic pregnancy occurs when the fertilized egg implants outside the uterus, most commonly in the fallopian tube. This is a medical emergency that presents with unilateral stabbing pain in the lower abdomen and vaginal bleeding. Preeclampsia is a serious blood pressure disorder that typically develops after 20 weeks. Its classic signs are hypertension, proteinuria, which means protein in the urine, and edema. Severe features include severe headaches, vision changes, and epigastric pain. The only cure is delivery of the baby and placenta. Other serious conditions involve the placenta, placenta previa is when the placenta partially or completely covers the cervical opening. The hallmark sign is painless, bright red vaginal bleeding in the second or third trimester. In contrast, abruptio placentae is the premature separation of the placenta from the uterine wall. This is an emergency that presents with sudden, intense uterine pain and dark red vaginal bleeding. Both conditions can be life-threatening for the mother and fetus and require immediate medical intervention. Recognizing the difference between these two is a classic NCLEX topic. So remember, previa is painless, abruptio is agonizing. As you prepare for the maternity section of the NCLEX, remember that you have learned so much already. The key now is to organize that information in a way that makes sense to you. For complex topics, use mnemonics. For example, to remember the warning signs of pregnancy, you can use the acronym PREGNANCY. Preeclampsia signs like headache and vision changes, rupture of membranes, epigastric pain, gushing fluid, no fetal movement, abdominal pain that's severe, nausea or vomiting that's persistent, childbirth signs like contractions and yellowing of skin or jaundice. Creating these little memory aids can make a huge difference under the pressure of the exam. Another great tip is to focus on understanding the why behind everything. Don't just memorize that a normal fetal heart rate is 110 to 160 beats per minute. Understand why a rate outside this range is concerning, because it could indicate fetal distress or hypoxia. Don't just memorize the GT-PAL system. Understand why a detailed obstetric history is crucial for identifying risks in the current pregnancy. When you understand the rationale, you can apply your knowledge to any question the NCLEX throws at you, even if the scenario is unfamiliar. This approach moves you from simple memorization to true clinical reasoning, which is exactly what the test is designed to assess. Practice questions are your best friend. Do as many NCLEX style maternity questions as you can find. Pay close attention not just to the questions you get wrong, but also the ones you get right. Read every single rationale. Sometimes you might get a question right for the wrong reason, and the rationale will clarify the correct thought process. This active learning process will help you identify your weak spots and solidify your understanding of key concepts. Look for resources like UWorld, Kaplan, or even the practice questions on my website www.brispainternational.com to get high-quality practice. Finally, please remember to take care of yourself during this stressful time. You are studying to become a nurse, a profession all about caring for others, but you must start by caring for yourself. Get enough sleep, eat well, and take breaks when you need them. You have worked so incredibly hard to get to this point. Be confident in your knowledge and your abilities. Walk into that testing center knowing that you are prepared, you have the dedication and the compassion to be an amazing nurse. I am cheering for you every step of the way. You've got this.